the death rate from prostate cancer in the first 5 years is practically 0%. Therefore, any treatment rendered is difficult to discern until you look at it decades later. The studies that have pointed at that have illuminated this detail. I don't think we should be treating prostate cancer with radiation, prostatectomy, or any other intervention. Early stage prostate cancer should be treated without biopsy, should be supported without surgery. Well, how the heck do you know if you have prostate cancer? I'm going to tell you why you should never get your prostate gland biopsied. That's a bold statement, but I'm going to back it up. This, of course, is my medical opinion based upon my research, clinical experience, and abundance of evidence. Never stick a needle in a prostate gland. Well then, you may wonder, how in the world are you going to diagnose prostate cancer? And how do you know if it's aggressive or not? You have to appreciate the fact that prostate cancer treatment has evolved based upon presumption of benefit, rational thought, but without evidence of actual good outcomes. It was in the late 1800s when the prostate gland was first removed in modern times. A surgeon in England declared it to be a rare disease. How do we get from there to where we are now? You realize, of course, that the death rate from prostate cancer, well, you don't realize, so I'll tell you, it's actually been going down year over year for the past 20 years or so. And yet the rate of newly diagnosed cases, according to the current criteria, goes up. That's a paradox. Why would death go down but diagnosis go up? The reason is that we're making a false diagnosis on a non-cancerous condition in the prostate gland. In fact, it's normal for the prostate gland to develop atypical cells. These cells get mistakenly labeled as cancerous by overzealous pathological interpretation. It's a fact that in studies, looking at men who die for other causes past the age of 90, the overwhelming majority of them have cancer cells within the prostate gland, even though they die of something else. Upwards of 80% in some studies. Well, if 80% of the population acquires a certain cell type, couldn't we call that normal or inevitable? Now, if you're inevitably going to get, here, you got to connect the dots here, folks. This gets a little bit complicated. If you're inevitably going to develop cells in the prostate gland that are labeled cancerous, and if the PSA level, the prostate-specific antigen, always goes up over time, you've got a conundrum. Because the trigger for biopsying the prostate, in many cases, is an elevation of PSA. Guy feels totally fine, goes to see the doctor, they do a blood test. Oh, your PSA went up from 2 to 5. We need to do a biopsy. Stop the presses. Do not do the biopsy. Nothing good comes of it. Now, before any test should be performed, a question needs to be asked. What are you going to do with the result? And how will it make a difference and improve my health? So let's start answering that question. It turns out an important study, 2 of them actually, came with a similar conclusion, looking at men with early stage curable prostate cancer. Half of them had the gland removed, the other half did nothing. I mean, literally nothing. They tracked them over about 20 years, and you know what they found? That the death rate was the same in both groups. Not only was it the same in both groups, those who had the gland out and those who didn't, but the death rate from metastatic prostate cancer was the same. Oh, wait a minute. You mean you had the gland removed, you suffered the misery of surgery. I don't care how great they tell you they are at clipping out your prostate. I don't care if the Da Vinci robot can come in at a zillion angles. You're sacrificing bladder control. You're sacrificing sexual vitality. You're exposing yourself to infection, to pain, to complications. Yeah, Some people die postoperatively. Yeah, blood clots can happen. Heart attacks can happen. And for what? No gain. I'm sorry to inform, no gain. All right, so taking out the gland. How about x-ray? How about radiation therapy? How about pellet implants? How about none of them have been shown to actually work? The reason is that you've got to wait 20 years. The death rate from prostate cancer in the first 5 years is practically 0%. Therefore, any treatment rendered is difficult to discern until you look at it decades later. The studies that have pointed at that have illuminated this detail. I don't think we should be treating prostate cancer with radiation, prostatectomy, or any other intervention. Early stage prostate cancer should be treated without biopsy, should be supported without surgery. Well, how the heck do you know if you have prostate cancer? If you don't biopsy it, you don't know. The point is, there's enough means of assessing it that you can make a reasonable judgment. That is, the PSA rises. Do not stick a needle in it. Among the bad things that happen, there's futility of treatment at the end of the rainbow. Sticking, and these are not needles, by the way. These are like core, like trocars that are plunged into the prostate gland, causing bleeding and pain. You bleed the lesion, you stick a needle in it, you pierce the seal. Now, many surgeons and doctors, they would like to convince you that there's no risk of metastatic spread by sticking a needle. Come on, folks. Use common sense. You stick a needle in a tumor and it bleeds. That ain't good. In fact, there are studies. These studies were done on women with breast cancer. And what they found in this study, and it is informative regarding needle biopsies in general. Two groups of women with very suspicious looking mammogram results, likely cancer. One group went directly to a lumpectomy without a biopsy, took it out. The other group had a biopsy first, followed by a lumpectomy. The folks with the biopsy had a much higher rate of metastatic disease subsequently. All right, that's interesting. Another study where they did needle biopsies and then the women subsequently had a mastectomy or a lumpectomy. They analyzed the tissue, and you know what they found? They found several of them, significant numbers of them, had cancer cells along the needle track. So there is clear evidence that this can happen. Stop denying it as a risk factor. The prostate gland works to contain abnormal cells. This is what the body does. If you get an infection, it tries to wall it off. If you get cancer, it tries to wall it off. Don't screw with it. So you stick a needle in, you can spread the cancer. You stick a needle in, that'll lead to what? There's an approach to men with elevated PSA. It's called conservative monitoring, watchful waiting, active surveillance. It has these different names. It means we're going to biopsy you, Dr. Petteruti, we're going to stick a needle in your prostate every 6 months just to see what's happening. You cannot predict what comes next based upon the result of a needle biopsy in the moment. That is fiction. That is speculative hope. I'm going to biopsy your prostate and I will be able to then determine whether we should remove. We already decided, we've already concluded, we already have evidence that taking the gland out causes harm. Here's the big problem though, psychological and practical. So now we've got this elevated PSA. Now perhaps a biopsy is done and we have a diagnosis of early stage cancer or suspicious looking cells. Where do we go from there? The doctors would say, well, we can take out the gland or we can do nothing. Folks, that's psychologically untenable. And it is impractical and it is not consistent with what we know about the biology of Homo sapiens. Your body, my body, our bodies are fighting cancer every day. Our immune system is killing cancer cells. We're trying to keep it in the box. The goal is to have the prostate contain any would-be cancerous cells within the gland. They will never hurt you if they stay in the gland. You can't die from prostate cancer unless it metastasizes. Keep it in the gland. Let the body wall it off. So the intellectual medicine approach, this is a desperately needed facet of consideration for prostate cancer and for evaluation of elevated PSA. Over the years, and I've been studying this now for over 10 years, looking at the literature and applying it in practice to patients at my office in intellectual medicine, those who make this choice. Elevated PSA. You get an MRI of the prostate gland. The prostate MRI can help determine what the anatomy looks like. Are there nodules? They can rate it. It's called a BI-RADS score, 0 to 6. 6 means, yeah, buddy, you got cancer. 0 means, it's not there. Usually it falls in between. BI-RADS of 4, it's probably cancer. I have a cluster of these patients in my practice. BI-RADS is 4, PSA is raised, it's elevated. Now what? Now we go to work. One of the things we do, eliminate known carcinogens. One of them, cadmium. You all have it in your body. I hate to report it, but it's a polluted world out there. Cancer is largely environmental. If you have a carcinogen in your body, you got to reduce it. So we've developed means of reducing cadmium and other carcinogens. Intravenous infusions can help. There are prescription medicines. Dimercaptylsuccinic acid is one. All right, so that's one component. How about other components? Sirolimus intervenes with mitochondrial dysfunction. That's where cancer lives. Certain supplements can have value as well when used in combination. Ivermectin, it's got a niche, shown to have some benefit. Metformin, another niche. These are repurposed drugs that are utilized because evidence has supported potential benefit in being aggressive against cancer. We want to create an environment in your body that is inhospitable to cancer. So you do not need to make a choice between doing nothing and having aggressive surgery without any hope, not any hope, but rather with no proof that it's going to cure you. But guaranteed harm. 100% guaranteed, don't bat an eye, it's going to hurt you. Then, if it gets even worse, if the prostate cancer advances after they've already whacked your gland out, they then castrate you. All right, they call it androgen deprivation therapy. It's a nice euphemism for castration. I'm not for this, folks. I say fight prostate cancer like a man. Maintain your virility, your vitality, your strength. Use your body's own immune system, augmented by the intellectual medicine aspect of supportive care. Repurposed drugs, use of supplements, detoxifying carcinogens. Does it work? We have evidence of benefit. I've had patients I've been tracking now for 10 years in some cases. PSA levels remaining plateaued. MRI year over year without any aggressive change. And many of these men are on testosterone therapy while they are managing the PSA, while they are managing the nodules in the gland, while they are not getting biopsies done. Living life vitally. I encourage you to tune in the podcast with the Baron, a man I admire, 81 years old. He's had prostate cancer most of his adult life. He's opted not to have any aggressive surgery or removal of the gland, no radiation therapy. He goes to work every day. He's had a vital life. He's now in his early 80s, goes to work every day, the Baron. His PSA level, over 120. The PSA, folks, does not predict nor correlate with risk of death or metastatic process. It's merely a shadow indicator. So I asked him, as you'll see if you watch that podcast, if you found out tomorrow that the cancer had metastasized, would you regret not having done something more aggressive? He said, no. He said, I've had a great life. I feel wonderful. I feel wonderful. Vitality, vertical living, strength, virility, fight cancer like a man. Hey, listen, if there's a cure out there, if there's a guaranteed cure, yeah, sign me up. If you're going to cause harm to a patient, if you're going to impose hardship, guaranteed hardship, there's got to be a big payout at the end. There's got to be a holy cow moment. It's got to be, you would have been dead but for. Another study is informative. Following prostate cancer patients out unto their death, over 250 of them. Of the 250 who died, approximately 23 died from prostate cancer. The rest, they died from other causes. Look, prostate cancer is real. It's a concern. However, cutting out the gland is not the solution. Biopsying has no merit or value regarding survival. These are all things that have evolved. The standard of care has grown out of presumptions without real scrutiny of benefit, in part because there's a vacuum of alternatives. Well, I'm sharing with you an alternative. I do have a forthcoming book. I'll be talking about it, and when it's out, you can bet I'll be making you aware of it. Why? Because we really need to hold on to vitality. We really need options. Given the option, given the information, if you choose to get a biopsy, it's not the wrong choice. It's the wrong information if you're told that's the only path. Biopsy or nothing. Prostate removal or nothing. No, there's a big in between, and we're developing it. We've developed it. So folks, when it comes to prostate cancer specifically, go slowly, think hard, gain information. Do not let them stick a needle in there. It is optional, not a requirement. There's not much to be gained, if anything. All right, well then, that's all there is about prostate in this moment, but I'll have more to say in times to come. Thanks so much for being a part of this podcast, and I'll look forward to our next conversation. See you then.